Few minutes as some more folks are joining. Sorry about that. Welcome everyone to our March webinar. We're really excited to have everybody here and really excited to have some great guests that we'll be able to hear from today. So you probably already know this unless you're in the wrong place, but this is the Susan G. Komen webinar. And together we will create a world without breast cancer. And we want to introduce ourselves to you really quickly. I have met many of you so far, but my name is Brandy Engelberger, and I am the State Executive Director for the Pennsylvania market for Susan G. Komen. I joined the team earlier this year and really excited to have met some of you. Really love that we are able to come together and share these webinars monthly. And I'm gonna let the rest of our team introduce themselves, who you have hopefully been able to meet before too. So I'll pass it over to Molly really quick to introduce herself.
Hi, good afternoon. My name is Molly Sweet, and I'm the development manager here in Pittsburgh. So I oversee all things Western PA. Taylor?
My name's Taylor Kazoka. I'm the development manager for Eastern PA, so covering everywhere from Scranton to Harrisburg and mainly the greater Philadelphia area.
And there we go. Really quick, want to do a quick happy Women's History Month. As we know, it's Women's History Month. And so we thought today we would kick things off with a little bit of history about Susan G. Komen and how far we've come, where we started, and where we're going. So I'm going to pass that over to Ms. Taylor.
Hey everybody. So I just want to start by sharing what our mission is and why you guys are here. So for us, our mission is to save lives by meeting the most critical needs in our communities and investing in breakthrough research to prevent and cure breast cancer, part of which you'll hear about later today. And obviously our vision is very simple. It's a world without breast cancer. So I just want to talk a little bit about the history of breast cancer. Back in the 1950s, it was sort of taboo. The New York Times refused to publish any ad for breast cancer support, and they would not share the words breast or cancer. We've come a long way since then. In 1969, the modern mammogram was invented, which has saved countless lives from breast cancer. In 1970, the standard treatment for breast cancer was a one-step surgical process. We obviously all know that that is not the case, and every case is different. 1972, that taboo feeling of we can't mention breast cancer kind of lifted a little bit when Shirley Temple, the animal crackers in my soup girl, becomes the first in a series of well-known figures to publicly announce her breast cancer diagnosis. And finally, in 1980, sadly, after a 3-year battle with breast cancer, Susan G. Komen, or Susie, dies at the age of 36. And the Susan G. Komen Foundation would not be where we're at without Nancy, because she made a promise to her sister Susie that she would help create a world without breast cancer. Her sister actually said, Susie actually said, as soon as I get better, let's do something about this. Unfortunately, as we know, she did pass away, but we did keep her legacy alive. And that's where the birth of Susan G. Komen comes from. So we were established in 1982 by Nancy Brinker. The first year of Susan G. Komen, where she had money saved in a shoebox, we awarded our first research grant of $28,000 to Dr. Gary Spitzer at the University of Texas MD Anderson Cancer Center. In 1983, the first race for the cure takes place in Dallas, Texas, with 800 participants. And in 1986, the first Breast Cancer Awareness Month is held in October. In 1992, Komen awards the first Brinker Awards for scientific distinction to Drs. Bernard Fisher and Dr. V. Craig Jordan. And we've come a long way since then. Today, we've helped reduce the breast cancer mortality rate by 42% since 1989. We've invested nearly $1.1 billion in research, leading to new ways to prevent, diagnose, and better treat breast cancer to further our goal of high quality care. The last year, we invested more than $7.7 million in community health programs to ensure people get the help they need to understand the disease, access screening and diagnostic exams, remove barriers to care, and receive support every step of the way. But our mission still continues because still there are 3.8 million breast cancer survivors living in the United States. Improvements in early detection and treatments reduce the breast cancer by 42%. However, more than 44,000 people in the US will be diagnosed with breast cancer this year, and disparity still persists among the minority groups and those living in rural areas. Breast cancer treatment can cause emotional and financial strain that forces patients to choose between their health and other needs that we have been continuously working with. One thing we could do is reduce breast cancer disparities by 30% today without a single new breakthrough, if we could just get people access to the care and support that they need and what is available today. And as many of us know, importance to access to care is very critical. Those who are uninsured or are underinsured or uninsured tend to force or delay screenings, which can lead to a late stage breast cancer diagnosis instead of an earlier stage that's more treatable. The longer it takes an individual to detect breast cancer, the quicker their 5-year survival rate declines. Unexpected costs cause many people to cancel or delay recommended diagnostic testing. And the average out-of-pocket cost for an insured person for a diagnostic exam or diagnostic mammogram is $234 and over $1,000 for a breast MRI. To help battle this, we have expanded our screening and diagnostic programs to 10 key cities in our trial studies of this. One being Philadelphia. So if somebody is in need of a screening and diagnostic exam, they do not live in the regions highlighted, they are more than happy to call our helpline and we'll be able to help them find a low cost or free mammogram. If you do live in one of these cities, you can call our helpline and we will give you a voucher to go to a local hospital system. If you're local to the Philadelphia area, that would be UPenn, ChristianaCare, or Mainline Health, where you can receive a free mammogram up to a biopsy covered by Komen. As I mentioned, our helpline, they're offering support provided by trained specialists in oncology social workers. They answer any and all questions. Sometimes I'm amazed at what they know and how they can answer it. They're able to help you find mammograms. They're able to give you emotional support. We have patient navigators who are here. If you saw our last webinar, we had 2 patient navigators join us. They're able to provide so much support, give people financial assistance that they need, anything that they have to help them with their breast cancer journey. So in order to call our helpline, you can call at 1-877-GO-KOMEN. And they can also assist with our financial assistance program, which would provide a one-time check to a breast cancer patient in stages 1 to 3 for $500, or somebody currently with metastatic breast cancer for $750. We know the cost of breast cancer is outrageous. People have to cut back on work or not be able to work at all. And those bills start really adding up. So this would be able to help somebody with rent, transportation, food, medicine, etc. In order to qualify for this, you would need to be 300% below the federal poverty line, which for a family of 4 is about $90,000, I want to say. So really a lot qualify for this and they just don't know it. So please call our helpline if you think you're available and they're more than happy to assist you. And I want to pass it over to Molly.
Thanks, Taylor. Welcome everybody. So in 2023 and moving forward, a key initiative of Komen's mission is advancing health equity. And when we talk about health equity, we're talking about addressing in a very real way how this is tackled. We are tackling it with the main we're tackling the main components of health disparities, such as discrimination and the consequences of such, because we know that these lead to feelings of powerlessness and a real lack of access. One of our flagship health equity programs is our program focused on Black patients in 10 U.S. metropolitan areas across the country that have the worst breast cancer disparities. This initiative is called Stand for Her, a health equity revolution. And the goal is to reduce breast cancer disparities in the Black community by 25%, starting, because you have to start somewhere, in these 10 metropolitan areas. So what did Komen do? Komen conducted a landscape analysis in these 10 cities to determine and describe the systemic barriers that may contribute to breast cancer inequities, and to fully understand individual, community, and health systems factors that are contributing to these cancer inequities. Among many other learnings from the landscape analysis, we confirmed that access to care is playing a huge part in the disparities being experienced in these cities and beyond. We finalized the landmark report with detailed statistics about the lived experience of breast cancer in the Black community and recommendations for interventions to support health equity in these 10 metropolitan areas. So what have we done? We've hired and trained 6 culturally competent Komen patient navigators to serve patients in the metropolitan areas. We've developed and launched a first of its kind training module on navigating racism and bias in the healthcare system for Black patients. We trained 73 Black individuals through Komen's Navigation Nation, a web-based, self-paced patient navigation training program for professional development as well. We have served 968 Black patients living in the designated metropolitan areas of the program through Komen's Financial Assistance Program, and 1,602 people who self-reported as Black through Komen's Breast Care Helpline in the past year. And at federal and state levels, Komen's Center for Public Policy works to secure hundreds of millions of dollars in breast cancer research, safety net programs, and support needed to make policy changes every year. And we need your help. Become an advocate. You can get involved with Komen's work to improve outcomes and save lives through sound public policy. And becoming an advocate is really easy. You simply have to text Komen to 40649. You will be able to use Komen's technology to reach out to your elected representatives to drive real and lasting change. And yes, the staff and representatives do read these messages and they do consider these real issues, especially when all of us actually push together. I will now remind everybody that Susan G. Komen is the largest funder of breast cancer research next to the US government. And so on the next slide, we're going to discuss, okay, so what does that mean? Where all these research dollars get allocated to? And here you can see the breakdown of the active area, the most active area being research investment, the majority of which, 57%, focus on incurable, metastatic, and/or a reoccurrence of cancer, followed by treatment and prevention. We are currently funding 39 active clinical trials, and I'm proud to say quite a bit of work is being done right here in Pennsylvania, which we're going to hear about today from UPMC and Komen Scholars, Dr. Steffi Ulrich and Dr. Adrian Lee, on what they're working on today. So without further ado, it's my distinct pleasure to introduce you to Dr. Steffi Ulrich, who is PhD in Pittsburgh's Foundation Chair of Precision Medicine. She's also a professor of in the Department of Pharmacology and Chemical Biology at the University of Pittsburgh. And she is the director of the Institute for Precision Medicine at UPMC Cancer Institute. Not to be outdone by Dr. Lee, who is the Pittsburgh Foundation Chair of Precision Medicine, professor of the Department also of Pharmacology and Chemical Biology at University of Pittsburgh. He is the director of the Institute for Precision Medicine at UPMC Cancer Institute, and he is also Komen's Komen's National Board of Scientific Advisory Board. Welcome, Dr. Lee and Dr. Ulrich, and we look forward to hearing what you've been working on.
That's great. Thank you so much, Molly and everyone, for the introduction and giving us a chance to present some of our data here today. So I think if it's okay, I just go ahead and share my screen and start the presentation, yeah? Great. Okay, here we go. So The title of the presentation today will be Updates on Breast Cancer Research here in Pittsburgh. And we already had a great introduction from Molly on for Adrian and myself. I should actually also say that Adrian and I are married. We are a couple. I grew up in Germany, in Berlin, got my degree there. Adrian in London. We met as postdocs in San Antonio, Texas. We were then faculty at Baylor College of Medicine in Houston, and since 2012, we are here in Pittsburgh, which I should say, actually, we have thoroughly enjoyed here. We really, really like Pittsburgh. So again, briefly, you already heard about this. We are professors here at the university. I co-direct the Women's Cancer Research Center, which is a collaboration between Hillman Cancer Center and McGee Women's Research Institute, and co-lead the Cancer Biology Program, and Adrian direct the Institute of Precision Medicine. And, you know, we have been funded by Komen, actually early on as trainees, and then over the years, Adrian was a Komen Scholar for many years and is now on the Scientific Advisory Board, and I'm still a Komen Scholar, and we have so many ties to Komen for the last, 20 plus years. They have been playing an absolutely important role in our career development, in our research, and now, for the careers of the people we have in the lab. And I think Komen has really allowed us to make tremendous progress in the research. And in the end, the research is what really drives progress and what changes lives for patients with breast cancer. So we have put a few slides together to summarize some of the research that's ongoing. So here, just as a reminder, the diagnosis of patients with breast cancer is the number one cases of cancer. And we unfortunately still have 40,000 deaths from breast cancer each year just in the US alone. This was a really nice review, which was published now almost 3 years ago. From Gabriel Hortobagi, how treatment has changed over the year. Obviously, in the beginning was just surgery, and then other kinds of treatments were added, like hormonal therapy, how it has changed over the years, radiation, chemotherapy, and now over the recent, 20, 30 plus year is targeted therapy. Targeted therapy in the way that you have one specific target in the cell, which you develop a drug for. So hopefully having less cytotoxicity, less side effects for other non-cancer cells, although we all know that even with the targeted therapies like HER2 and immune therapy, unfortunately, we still have major side effects. Yeah? But to summarize this, there has been tremendous progress over the last 30 to 40 years. And overall, there's a 40% decrease in breast cancer death over the last 30 years. We included one slide here. Actually, you know what? I just realized, Adrian, I don't know if you want to say something to introduce yourself. I just kept going. Maybe you should say a few words as well. I am so sorry. Maybe I give it back to you. I just won over you, Adrian.
I wondered if you were going to stop.
Maybe you should say a few words about yourself too.
I wondered if you were going to stop and you were going to give me a chance to say something. Well,
okay, here we go, Dr. Lee.
Welcome, everyone. It's great that you're here. I think for those of you that know, Steffi and I are married and we're very passionate about breast cancer research. We were, as Steffi said, very fortunate to be funded by Komen. Both of us, our career started with Komen funding. Since then, we've continued to do breast cancer research. We were super excited to come to Pittsburgh about 12 years ago, built one of the top national programs, and continue to work with Komen and try and spread the message and try and do cutting edge research that, improves the health of women here in Pittsburgh and then the health of women nationwide. And I'm leaving today up to Steffi to do the talking.
Okay, sorry about that, Adrian. And you can always chime in later on again, feel free. So let me get back to the presentation. So let me move this out of the way. So I have one slide on this one, which is a bit more complicated, but I will guide you through this. I do think it's important. you know, the main message is that breast cancer is very, very heterogeneous, and one cancer is not the same as another cancer. And we differentiate between two different subtypes. So one is called histological subtype, and one is called the molecular subtype, so intrinsic subtype, or we call it also PAM50. Just briefly about the breast cancer. So in the breast, we have these ducts, breast ducts. They all connect to the nipple. We obviously have a lot of other tissues in there, other cell types, like the most dominant is our adipocytes, which are fat cells, yeah? But you also have muscle, you have immune cells, you have blood vessels. And when you take one of those ducts, you have a lumen in the middle. That's where the milk goes through. And then on the outside, you have these epithelial cell layer, which are this is where the cancer grows. So between the different histological subtypes, we have ductal cancer and we have lobular cancer. So lobular cancer is actually, I should say already, this is one of the focus area of our research. Yeah. And when you look at molecular subtypes, we differentiate between basal-like, which clinically is very often described as triple negative breast cancer. It doesn't have estrogen receptor, progesterone receptor, or HER2. We have HER2 enriched breast cancer, where the oncogene HER2 is overexpressed. And then we have luminal breast cancer. We have luminal B and luminal A breast cancer. And the luminal breast cancers are characterized by expression of the estrogen receptor. This is shown here on the bottom. So the more you go from the left to the right, the more estrogen receptor you express, or the tumor expresses, and the more responsive the tumor is to hormonal therapy, like tamoxifen, aromatase inhibitors. So all of these factors which are on here, the histological, especially the molecular subtypes, ER status, the lymph node involvement, the size of the tumor, tumor grade and stage. These are all factors which are decision-making for the physician in how to treat the tumor. So the challenge really is that although most of the breast cancers are diagnosed at a curable stage when it's only in the breast, that we have approximately 20% of patients where unfortunately the cancer relapses in other organs. This is metastatic disease. And like I mentioned earlier, this is what patients die from. And we have approximately 40,000 women and men who die of metastatic breast cancer each year. And the majority of breast cancer studies until approximately 10 years ago, I would think, was based on really understanding the primary breast cancer. But over the last decade, I think, and there was Molly showed the slide, there's been a lot of effort and resources also to understand metastatic disease. And I think we have made major progress in the area. This is a slide from the review from Nadia Harbeck, summarizing where breast cancer metastasizes to. And it can spread over various ways, over the lymph system, over the blood vessels, or over the lymphatic system. And you can see that the majority of metastasis, in addition to obviously to the lymph nodes, to the adjacent lymph nodes, otherwise the majority of metastasis is to the bone. Approximately 70%, especially ER positive breast cancer, metastasized to the bone and to the liver and to the lung. We also see metastasis in the brain, peritoneal region, in the ovary, in the gut. But this is really where the major problem is, and this is what a large number of groups all over the world have really focused on over the last decade. So in the second part, I'm going to focus on discussing the Women's Cancer Research Center, maybe a couple of areas in breast cancer research, which are focus areas and where we have made major discoveries over the last few years. Pittsburgh is a unique place for breast cancer research for the reasons listed here and additional reasons which are not listed here. It has a very large integrated clinical research program. There are more than 1,300 new patients a year, which are all seen here at Pittsburgh. So a lot of the patients from the surrounding, from the rural areas, from other larger cities come to be seen by experts here in Pittsburgh. There's a very big data collection within the UPMC system. There's data there for more than 50,000 breast cancer patients. And these days, as you know, a lot of research can be done on the computer, I think, to try to figure out, are there patterns? And especially then if we sequence those samples, we can identify specific pathways in the tumor, maybe actually not only in the tumor, but the entire patient, the environment, what might drive tumorigenesis and progression. There are lots of collaboration, not only within the US, but internationally, interaction with Carnegie Mellon, strong computational expertise. The tissue collection program is really it's a really strength here. And that's actually, I should say, one of many reasons why Adrian and I moved here from Houston 12 years ago. Fantastic clinical trials consortium with the NSABP. That program has made major contributions to breast cancer care, to changing breast cancer care. One of the examples is to show that in many patients, breast conserving therapy has the same outcome as compared to mastectomy, although not in all. And there's close ties with the community. Komen, one of them, breast cancer advocacy. So the Women's Cancer Research Center was founded in 2010 as a collaboration between the Hillman Cancer Center and the McGee Women Research Institute. And the major goal are to translate knowledge of biology of women's cancer into personalized prevention and treatment. Education of researchers, physicians, and the public about advances in women's cancer, to train and educate the next generation of women's cancer physician and researcher. And finally, to harness and power of the system-wide resources to advance discovery and improve outcome. The focus area are different subtypes. Sorry, like I said, the heterogeneity of breast cancer, understanding what's different between ER-positive, triple-negative breast cancer, a focus area on lobular breast cancer. Metastatic disease, for example, understanding changes in the estrogen receptor, which are in approximately 30 to 50% of endocrine treatment resistant disease. Organ donation program, and I'll come back to that. Understanding the role of the immune system, where we in breast cancer lag behind some of the other cancer types like melanoma and lung cancer. Racial disparities in breast cancer outcome has really, there has been research in Pittsburgh for many years, but it has become even more of a focus area now, and personalized medicine. So I'll just touch a little bit, touch base on some of those. Invasive lobular breast cancer I mentioned earlier. This affects approximately 10 to 15% of all breast cancers. It has been understudied, but I think we have really contributed to making physicians, researchers, patients realize this is an independent disease which deserves to be studied more. We have contributed to understanding of the biology of this disease. We have formed a Great Lakes ILC consortium, so we work very closely with Case Western, Cleveland Clinic, OSU, and here in Pittsburgh to make progress. We have recently characterized more than 30,000 patients with ductal and globular cancer and compared and contrasted different features of the disease. And we have the first ever trial, exclusive patient for ILC, here in Pittsburgh, collaborating with many other sites. And I think I should say that this has been funded through a career development award by Komen. We have a meeting here coming up, an ILC symposium in September in Pittsburgh, where we get leading researchers and physicians and breast cancer advocates from all over the world together to discuss the disease, the progress which has been made. We interact closely with patient advocates as well, with LBCA, as well as a growing international group of ILC advocates, nicely called the Globe Mob. made progress in immune therapy. This is the first ever large randomized trial. This is patients with triple negative disease where we have seen, I should say this is a Kaplan-Meier survival curve. So this is months of treatment, either with chemotherapy with placebo or chemotherapy with an immune targeting agent. And this is the percent of patients which have then additional relapses of the disease. And you can see with the addition of immune therapy, the curve is shifted to the right. So patient relapse later, the tumor comes back later. So there's progress there. For the longest time, this was only in triple negative disease. We clearly need to make more progress in triple negative as well as in ER positive disease. We here in Pittsburgh, Adrian and I have collaborated with a large number of investigators shown here on the bottom, really with different expertise in immunology, in pathology, in bioinformatics, surgery, and all of us have made a really large effort to also understand immune infiltration in estrogen receptor positive disease. So this is a focus area. We have a couple of papers out. We have great, really exciting studies, and hopefully more to come over the next few years. We have also a focus on reducing therapy in the elderly, especially with ER positive breast cancer. As you know, over the last 30 to 40 years, we always try to get newer therapies, and the more the better. This is now, I think, more, it has come to the point that we really try to think if there's room for de-escalation of therapy. So when is there no need to give chemotherapy, to give hormone therapy, to have surgery, to give radiation? This is a active project in close collaboration with physicians. It's directed by the student Neil in the lab. And I think Adrian put the slide together, and he put this, there was a write-up in the paper, and I think he put the whole thing on here because on the same paper there was an article with Bruce Willis. We were very proud to have a write-up in the paper together with Bruce Willis. Anyway, I think this is a major focus areas. The research is going on, and we think there will be lots of excitement over the next few years. I mentioned already the tissue donation program. Pittsburgh has a program where patient can consent to organ donation at the time of death. It was in the past, it was called a rapid autopsy program, but we worked very closely with a large number of patients and advocates. And one of the first things they did actually was renaming the program. They didn't like the term autopsy, and our program here in Pittsburgh is now called Hope for Others. Others standing for our tissue, helping enhance research and science. We have performed 26 autopsies, 60 patients have consented, and it has already helped to make tremendous progress in actually identifying a change in the estrogen receptor, which they're so-called estrogen receptor fusions, which we have identified in these metastatic lesions. And there is a lot of collaborations ongoing nationally and internationally to sequence these most valuable samples were really given by the patients as the ultimate gift and contribution to science. And we are very excited about this. We have no doubt that these tissues will be used for the most exciting science using state-of-the-art approaches, and will result in major progress helping other patients to survive from the disease. This is one of the examples which we have discovered comparing primary tissue and metastatic disease, where we sequenced the primary tumor, sequenced metastatic disease, and identified that in the metastasis, approximately in 20% of the patients, the metastatic lesion suddenly expresses a gene called HER2. So it wasn't seen at all in the primary tumor. So if you base your therapy only on the primary tumor and do not biopsy the metastatic lesion, you could potentially miss out on drug targets which have arisen as a result of the evolution of the change of the tumor over time. So this is an example where we have massive expression of HER2 in the brain metastasis and not in the primary. And this is a genetic analysis. This is basically the chromosomes in the genome. And you can see the chromosome where HER2, where the gene for HER2, which is called ERB2, is localized, is amplified. So you have suddenly more of the DNA, you express more, and you can treat the patient with HER2 targeted therapies. So not in all cases you can have biopsy of the solid metastasis. You know, this is much easier said than done. In some cases, it's just not possible based on where the metastasis is. And for sure, you can't do it multiple times. So there's a lot of excitement about something called liquid biopsy. Liquid biopsy basically is looking at the tumor in blood. So you can take blood, obviously a lot easier as compared to doing a biopsy of a metastasis in the bone, liver, lung, brain. And the technologies have improved so much that we can detect changes in the tumor in very tiny amounts of blood. And this is used, for example, we can detect residual disease after the surgery, or we can monitor response and treatment is given and suddenly mutations come up, more DNA from the tumor is shed into the blood. There might be the need to change therapies, or we can, or I should say, or monitor how different parts of the tumor potentially change. They undergo evolution. Maybe you have new mutation, and again, maybe there's a new opportunity for alteration of therapy. There's lots of happening in that space. Should say that we have worked very closely with our physicians in the clinic, and a lot of the patients with metastatic breast cancer are consenting to say, yes, you know, just taking a little bit more blood, which we could then use for research to understand evolution of disease, and patients thankfully agree to that. Yeah. So this is, we have started this in September of 2018 and have now collected more than 700 bloods from more than 200 patients. So from some patients, we only have one tube of blood at one time of progression. And from some, we have, you know, 6, 7, 8, 9, 10, 11. And we are now started to analyze this blood, and we are working with different collaborators, different technologies to try to understand what is changing in blood and how does it reflect changes in the tumor. So see, we very closely work with breast cancer advocates locally, nationally, internationally. I just list a few here. This is not limited to the ones I'm putting here, but I want to make a pitch specifically for the local advocacy group, BC-RAN, the Breast Cancer Research Advocacy Network here in Pittsburgh. And, you know, we are looking for more members. So email the team, go on the website or email me. This is a fantastic group. They meet once a month, sometimes more than this. We work also very closely with them. They have a number of events ongoing. Yeah, so let us know if anybody is interested. So to summarize, the group here is really nationally, internationally recognized for leading breast cancer research in a number of areas: biobanking, research, data analysis. Research progress comes from collaboration, transdisciplinary collaboration, people with different expertise together onto a table. We have collaborations in Pittsburgh, nationally, internationally. Very strong interaction with the local BC-RAN as well as national international advocate communities. Increased funding through the NCI Foundation's philanthropy. As you know, every dollar counts. I think research is expensive, and the funding really is what's securing us to make continued progress. And we also do take pride, and we take it very serious that we, recruit the next generation of breast cancer researchers and clinicians and successfully train them. I think they are the future. They are the future to continue to make progress and to cure breast cancer. And I think this is all I have, and I will stop sharing. And Adrian, maybe I give it over to you again.
Oh, I think you said everything. I think, Steffi gave the summary of our whole program. I think we'd be happy to take questions or answer any comments.
If anyone has questions, feel free to come off mute, or you can type it in the chat box as well.
Thanks. This was interesting. I have a question about the liquid biopsies. Is there any evaluation of using them for a diagnostic tool, or is it only used following diagnosis for follow-up?
Yes, so I should say it's already, and I give it over to Adrian as well now. I think Adrian works a lot on liquid biopsy in the breast cancer area and also as part of the precision medicine initiative. So it is standard of care. It is used for patients at this point in time. But, like I said, we can always do more. At the moment, it is used to detect mutations, for example, the estrogen receptor. And I should say, as of January, as of 2 months ago, there is now a new therapy approved specifically in the setting with mutant breast cancer. There's a new, what we call oral SERT, which actually requires the identification of this mutation. So now it is more important than ever, even in the setting of positive disease, to look for mutations in the blood. But it has been around for quite a while now. It is used on a regular basis by the physician, but there's so much more room for improvement. Hopefully we can use smaller volumes. We can already in the adjuvant setting potentially detect really, really small amount of DNA. So have more sensitive techniques, not only in the metastatic setting. There's other stuff in blood, like not only DNA, but maybe RNA or CTCs, like tumor cells. And I think that's still under development. Adrian, maybe you can expand on this, yeah?
Yeah, Laurie, this is, for advocates, is always the burning question, because I think there isn't a single person that wouldn't switch out a solid tumor biopsy for a liquid biopsy or just a blood draw. And as such, it's the fastest growing area in clinical research at the moment, in cancer research by far. There's companies being spun out like every other day in this area. Here at Pitt and UPMC, we do it in essentially all 3 areas. We have open the test called GRAIL, which is for early detection. So that detects up to 50 cancers from a single blood draw, and that's open. We have a trial with a company called Natera, where we monitor disease. So after treatment, the blood biopsy should be negative, and you hope it's going to stay negative. And if it comes positive, then we know we need to give more treatment. So that's monitoring of residual disease. And then, as Steffi said, we have it for finding mutations. So more kind of what you said. It's not really truly the diagnosis of disease, like in early breast cancer. It's more kind of the diagnosis in metastatic breast cancer, kind of what the flavor of metastatic breast cancer it is. But it's a rapidly growing field, and probably, I think most people believe it will be transformative for how we research breast cancer and then how we treat it.
Thanks. I'd like to ask a follow-up question. I don't want to hog the floor, though. So follow-up question would be related to where patients can obtain the blood test. So my specific question is, do they need to be integral to Pittsburgh or UPMC, or what if they're in a county that's far away? Is this something that's pretty well translated to routine care, or is this highly specialized and patients wouldn't even know about it if they're 3 hours outside of Pittsburgh?
Yeah, so the beauty of it obviously is that any place can do a blood test. That's actually the transformative approach, in that if you need a MRI guided or CT guided biopsy, not many places can do that. And so patients then need to travel to the clinical trial or whatever, but any hospital can do a blood draw. And so, for example, we work with Pinnacle, our Pinnacle healthcare system. They draw bloods there, they send them to us. If the use of it is in the standard clinical setting, as Steffi said, this is now standard of care, then anyone can have it wherever. If it is our associated trial, they can have it done elsewhere. So, for example, the trial we have in Natera, which is in elderly patients who often struggle to come into Pittsburgh, the majority of those patients, I think 80% of them, we use mobile phlebotomy. So we have a car that just goes out, a company that just goes out and draws their blood at home and then brings it back to us. Patients love this. This is women over 70 years of age. So I think we had one yesterday who's 88. Yeah. So went out there, went to her home, drew her blood, came back. That's in reality is going to change how we deliver healthcare, obviously. Yeah. And I think that's the excitement, is that it will probably reduce inequity in the ability for people to get the care they need.
Thank you for that. Anybody else have questions or anything? Well, I cannot thank you both enough. This was incredibly educational and also very, provides a lot of hope for what we're doing. So thank you for what you do. Thank you for joining us today. We really appreciate it. And just so everybody knows, we will send this recording out. So if there's anybody that you think would have an interest in what we learned about today, by all means, please share that with them. We want people to know. And I think Taylor's just has a couple more slides she's going to pull up. So really quick, our next big event and chance to come together are our upcoming More Than Pink Walks. I believe many of you on the call are already planning to join us. But just a reminder of the dates and locations that are here. Per usual, East Pennsylvania will be on Mother's Day, as I believe everybody on the call should know that's participating in Pittsburgh. That will be a new date this year, just 1 week later on Sunday, May 21st. And we hope to see you at one of those. If you're not already signed up, you can do that right online at either komen.org/EastPA Walk or komen.org/Pittsburgh Walk. You can register as an individual there, or you can go ahead and get a team set up. I think most of us are registered, so hopefully we can start recruiting and fundraising. All the tools are there, but if there's anything you need that we can be of help with, whether it's doing some kind of rally or kickoff for your team or providing any kind of resources or guidance, we're happy to do that. Here are just a couple tips to kind of, as we say, put the fun in fundraising, but to go ahead and get started. Always encourage a self-donation. It's great to have some money in your thermometer that's on your personal page when people come to see how your progress towards your goal is going. The number one thing I can recommend for those of you that want to fundraise is to connect to Facebook if you have Facebook. I say that one because it's very, very simple to do. But additionally, a lot of us, I think, have a network on Facebook that we don't necessarily talk to regularly. And it's hard to know who within that network might have an interest in fighting against breast cancer. And so it's a great way to invite people that you might not know have a personal connection to help make an impact. For those striving to raise $100, an easy way to look at it is to ask 10 people for $10. Maybe give up a Starbucks 2 days or something like that to be able to make a $10 donation. You could always do something unique, garage sales, talent shows, bake sales, stuff like that. And then, of course, challenge the team to do something. Like I said, kind of give up Starbucks, do something like that, but try to give up an indulgence for a week, and then they can make that as their donation to their team. Really quick too, I had mentioned those of you striving to raise $100, or maybe your team members are striving to raise $100. Those people that do go ahead and do that will earn a commemorative t-shirt from the event. Survivors that are registered will also receive their survivor t-shirt. And for those people that want to earn their t-shirt and get it in the mail prior to event day, something that we can promise to do, we would ask that for East Pennsylvania, they have that $100 raised online by April 16th. And for Pittsburgh, that would be an April 23rd date. Those people that raise $100, but after those dates will of course still get their t-shirt. It just will not come in the mail as early, and it may not be there for event day. We also have other great incentives. We of course want to recognize and thank our VIPs who are our fundraisers who are helping to be able to do the type of research, to be able to make progress in terms of research and advocacy and community and all of that. So we have some really fun things this year. People can earn at different levels depending on how much money they raise. You can see photos here, but there's some pretty cool stuff. I love that towel, a tie-dye towel, looks pretty cool, and the duffel bag. So for those people that reach those goals, those incentives will come after the event. For those of you that are registered, you should recognize this. For those of you that are not registered, this is once you are registered, you would get a fundraising center that looks like this. Here you can actually tell your story. So if you send out your link through Facebook or through text or through email to friends or family, they can come to your page and actually read exactly what your reason is for participating and why it's so important to you. You could even add a photo. So, if you're walking in memory or in honor of somebody, you can add their photo. You can set a goal, and then it will automatically track your progress towards that goal through this thermometer type thing. And then, of course, you can view and event the participation details. We have a great app. For those of you that utilize apps, you can download it right in the App Store. And you can do everything that we just showed you on the personal page. You can also do right from the app. In addition to, you can even scan your checks. So if you get check donations, you can put them on right through the app. But you can also connect to Facebook. You can check your fundraising progress. Any kind of resources are available there. You can earn badges and all kinds of fun stuff on there.
And to just add one thing about our app, I just walked one of my constituents through it. She was using it to text participants. So you can log on and just be able to text your friends, text your family members. It's already a preset message with your link just to kind of get them going.
Thanks, Taylor. We have a Facebook group. So much of this event is about community, right? Supporting each other, getting to know each other. So we'd love for you to join the Komen Pennsylvania Facebook group. If you search Komen Pennsylvania more than Pink Whack, it'll come up. We post some, reminders in there, some fundraising tips. We acknowledge our top teams in there. So if you want to see your name on the leaderboard, and you can also post in there. So if you have a question or a great fundraising idea, or you want to share your story, you can do that there too. We are looking for volunteers for both of our events. So a few different opportunities. We are working to put together an official committee that will help kind of with the event experience. This is really your event, right? It's a community's event. We want it to be representative of the community. And so those people that have some thoughts or an interest in getting involved, we'd love to have you. Just let us know. Also day of, if you have some friends or family that maybe don't want to walk, can't walk the actual route, but want to come out and help out in some way, we are looking for volunteers the whole weekend, really, to set up the event. And then day of volunteers, we have a lot of roles for different tents and different activities that we're looking for people to help with. Our next webinar is April 12th at 12 p.m. So save the date. You'll get communication about that over the next several weeks. And then we do have a challenge going on for East Pennsylvania for St. Patrick's Day. We will have an exciting challenge coming out in Pittsburgh, so be on the lookout in your emails and the Facebook group. It will be, so in East Pennsylvania, some lucky winner is going to win what is called a goose basket from Wawa with a lot of goodies in it. And that's for anyone that raises $100 between March 15th and March 21st. We'll be doing the same challenge for Pittsburgh to win tickets to a Pirates game. So keep an eye on your email for that. And of course, we couldn't do what we do without our wonderful sponsors for both the East Pennsylvania and the Pittsburgh More Than Pink Block. So just a shout out to all these wonderful sponsors that are listed here. And any questions or anything that you need, this is myself, Molly, and Taylor, our email and our phone. We're here you support this great organization. We're here to support you in any way that we can, answer questions, help you get set up as a team. Like I mentioned, we'll be sending this webinar link out. So by all means, we'd love for you to share it with anyone that has an interest in this type of thing. And I just thank you all for joining us today. It was great to see some great faces. I know we're just about time, but if anybody has questions, feel free to come off of mute or put it in the chat box.
Just want to say thanks. I mean, this was really, really informative and good. Thank you.
So happy to hear that. Thanks, Lori. All right, well, like I said, be on the lookout for the link and just let us know if we can help with anything else.